All right, welcome. My name is Harman Chawla. I am a pediatric intensivist at Presbyterian Hospital.
And my name is Tom Weiler. I'm also a pediatric intensivist at Presbyterian.
We've gathered the body of literature surrounding COVID, and more specifically geared towards the pediatric population. And we have put these literature together and really help us standardize our care for patients that do have COVID-19. The real centerpiece of this talk is regarding diagnostics and therapeutic agents in pediatric critical care population. So with that, we will get started. Our recommendations that we will be providing from this discussion have really been compiled through three major sources. One of them is Pediatric Critical Care Medicine. The other is the Society of Critical Care Medicine, and more specifically, their Surviving Sepsis campaign that was geared towards COVID-19. And lastly, recommendations through the World Health Organization. In addition, we did take multiple other studies into account when putting together these recommendations. When we're starting off with diagnostics, again, this is more focused towards patients that have COVID-19 that are in the pediatric critical care setting. Upon admission, there are a number of labs that are recommended. The recommendation for these labs is primarily to establish baseline levels. A lot of these labs can be trended throughout the patient's hospital course, and labs such as CRP can track disease severity, and a variety of other labs can also be used to predict patient mortality, as persistently abnormal levels have been linked to higher mortality as well. The list of these labs is here for you on the screen to evaluate. In addition to establishing baseline labs, there are some that should be followed more longitudinally, and so we did put in recommendations for these labs. What's important to note is there is some degree of difference in between the body of literature for pediatrics compared to that of adults, especially when we look at markers such as lymphopenia, where 70% of adults have been shown to have lymphopenia with COVID-19 infections, and only 3.5% of children have shown this as well. In addition, I do want to make a point to say that if patients are on hydroxychloroquine or chloroquine, daily EKGs are recommended, if not more frequently, and this is more to monitor QTC intervals. Here is just kind of some markers to show predictors of mortality. As you can tell, there is a stark difference between some of these lab values, including troponin, myoglobin, CRP, and IL-6 for survivors and non-survivors of COVID-19. In addition, the DIC for survivors versus non-survivors is quite starkly different between for COVID-19 patients, for those that survived and those that didn't. So following these labs closely does become important for the population. From the radiologic standpoint, they have shown that children don't necessarily have the same X-ray findings. Chest CTs do have some degree of abnormalities, including ground glass opacification, as well as consolidation with surrounding halo sign. However, these are all non-specific findings. And with that, we'll turn it over to Dr. Weiler.
All right, so we'd like to just talk briefly about the compiled data on therapeutic agents, specifically for coronavirus and COVID-19 disease. And so we'll start with corticosteroids. This has been analyzed by the three governing bodies we mentioned at the outset. And they looked at the indication and the use of corticosteroids in terms of three different elements of the disease process of COVID-19. So specifically, we found that these patients, particularly those with a higher mortality rate, have a significant element of cytokine storm syndrome, or similar to hemophagocytosis. And then additionally, these patients can also experience respiratory failure from ARDS, and then sepsis or septic shock. Breaking it down, patients that experience cytokine storm syndrome essentially have a hyperinflammatory state, which is characterized by end organ dysfunction and elevated cytokine levels out of proportion to the initial disease process. And this is similar to HLH, as we said, and so therefore there is some thought that it may respond to immunosuppressive therapies. However, at this time, all the governing bodies so far have not been able to establish firm recommendations on the use of immunosuppressive agents, particularly corticosteroids. Secondarily, they looked at the use of corticosteroids for respiratory failures and breaking it down into two different groups. So those patients without ARDS and those with ARDS as defined by the Berlin criteria. And so the Surviving Sepsis campaign has recommended against the routine use of systemic corticosteroids for patients without ARDS. And then for those with ARDS, they do suggest using, quote, lower dosing and shorter duration for those patients with COVID-19. They derived this evidence from several different sources. So they looked at direct evidence from those initial studies that have studied patients with COVID-19. And unfortunately, these studies are of kind of low quality at this time, being either non-peer reviewed or not adjusted for confounders. They also were able to collect some indirect evidence from other disease processes. So patients with community-acquired pneumonia, ARDS of other etiologies, viral pneumonias of other types, and then other similar but not the same coronaviruses. With the compilation of all these data points, they do recommend this lower dosing in corticosteroids. And then looking at the third element of the disease process for sepsis or septic shock, they did find that based on meta-analyses of RCTs of patients with different etiologies of sepsis, that generally there is thought to be a small improvement in mortality and faster resolution of septic shock. And so at this time, they do recommend what they define as low-dose corticosteroid therapy. So patients who have cardiac dysfunction, who have refractory shock, defined as refractory to fluid resuscitation and vasoactive agents, you do recommend low-dose therapy, which they have suggested for hydrocortisone, for example, 200 milligrams per day of corticosteroid therapy for its mild benefits in previous studies. Additionally, they looked at the use of these. They do recommend in the Surviving Sepsis campaign using empiric antimicrobials. That's because it is difficult to diagnose co-infection in these patients, and up to 11% of them in initial case series have been found to have bacterial co-infection. And this data has been borne out in other types of viral pneumonias and showing benefit in those patients. Additionally, they do recommend acetaminophen for temperature to control to decrease the body's metabolic demand. And at this time, they're not able to make a comment on the use of NSAIDs, as there is some debate about that drug in COVID right now. Other agents of note, there's not really any good data in terms of able to draw conclusions for IVIG. And at this time, the Surviving Sepsis campaign has recommended against the use of IVIG due to the lack of information available and the potential for serious side effects. Another agent of note has been convalescent plasma. So this is plasma harvested from patients that have recovered from COVID-19 disease. It essentially works by providing passive immunity from preformed antibodies in these patients. They've looked at data from SARS, avian influenza, H1N1, and they found this to be inconclusive. So in addition to the concerns of optimal preparation and safety, they cannot make any recommendations. So they have suggested against the use of convalescent plasma at this time. Finally, these campaigns have looked at the use of specific antiviral and immunomodulatory drugs. As you might imagine, there's not a lot of hard data out there for these agents. You'll see that these are the basic mechanisms of all these drugs out there. The most notable one, which has been talked about, is chloroquine or hydroxychloroquine, which is an anti-malarial drug which has both antiviral and anti-malarial properties. And at this time, they really are not able to offer up any sufficient evidence to say for or against any of these agents, except for lopinavir or ritonavir, which is a drug used in HIV/AIDS. In terms of chloroquine or hydroxychloroquine, there is some hope that this will be a good therapeutic agent for these patients. But in a similar disease process where it has been tried in the past, including dengue, chikungunya, or influenza, it has not had any benefit. But people are still investigating, as there have been some initial reports, including an unpublished report and an open label non-randomized study, which seem to be promising so far. But at this time, no recommendation one way or the other. So that concludes our summary on initial diagnostics and therapeutics for COVID-19 disease. We'll try to post more updates regarding other elements of the disease process as they become available. Thank you.
Thank you.